Talk about Nabothean cysts. Nabothean cysts are the most common pathology that we see inside the cervix. This is the cervix, this is the lower uterine segment, this is the corpus or the body, this is the fundus. You're going to see Nabothean cyst in the meat of the cervix. They are going to be in the meat of the cervix, okay? They're asymptomatic. Basically, they're just a retention cyst because our body puts out liquid when we get excited, so that way our vagina's not dry when we have sex. And so it's these retention cysts that can get kind of clogged up like a blackhead. Okay? And then it builds like a little anechoic structure. Okay? Now, because ultrasound, depending on how we hit it, we can also have edge shadowing, okay, because of the way we hit the organ. We can also have posterior enhancement, meaning it's liquid. Ultrasound hits the liquid, and we have posterior enhancement. So you have edge shadowing, and you can have posterior enhancement. Okay. Another thing that we can have a polyp inside of our cervix. Okay? A polyp is usually sometimes they'll cause dysfunctional uterine bleeding. What's in the vagina? What's pathology inside the vagina? A Gartner's duct cyst. So here's my vagina, okay? And I could have a Gartner's duct cyst. Same thing can happen. Posterior enhancement and edge shadowing. Gartner's duct cyst come from the Mullerian or the Wolvian duct, depending on what is left. Okay, so here's my looking down into the vagina at the cervix. It's just a big fat muscle with a hole in the middle of it. This would be the external os. Okay, so here's the meat of the cervix. It's just a big fat muscle with a hole in the middle of it, and you can build up retention cyst or inclusion cyst of the cervix. They are anechoic. They can bleed, and if they bleed, they will be isoechoic to the cervix. Okay. Endometrial hyperplasia. Endometrial hyperplasia is when I have an overgrowth of endometrium. Here's my endometrium. This is my endometrium. So I will have an overgrowth of endometrium. Okay? An overgrowth, meaning it is stimulated to hormones such as high estrogen. Estrogen will do it. If someone is on hormone replacement therapy, I've had my ovaries removed for some reason, and I'm on hormone replacement therapy, and that will cause the endometrium to grow. Tamoxifen therapy. I have breast cancer. They're treating me with tamoxifen. It's a breast cancer drug. Okay? I could have diabetes. I could just be obese. I could have PCOS, polycystic ovarian syndrome, or PCOD, polycystic ovarian disease, dysfunction. Okay? It's where I have an overgrowth of my endometrium. With PCOS, I have anovulation, meaning I do not ovulate. Okay, I do not ovulate. So here is an endometrium that's overgrown. She's 62 years old. She probably is not on hormone replacement therapy unless she's had her ovaries removed. Okay, then she would be on hormone replacement therapy. But she has postmenopausal bleeding. Postmenopausal bleeding. I didn't have a period for a year. I had bleeding. It won't stop. That's called dysfunctional uterine bleeding. D-U-B. Dysfunctional uterine bleeding. This patient is on tamoxifen. What is tamoxifen for? Breast cancer. Specific for breast cancer. Okay? Here is a thickened endometrium, and you always want to measure it from outer wall to outer wall. Asherman syndrome. Asherman syndrome is synechia. It could be called either one. It's where I have had some type of a trauma, or I've had 10 miscarriages, or I've had 3 abortions, elective abortions. I've had C-sections. Okay? Anytime that my endometrium is, that they call that iatronic, when we cause it, instrumentation causes it, iatrogenic or something like that. And basically it's just adhesions that build up inside of the endometrium, and they are usually linear. So here is my endometrium, and I'll have adhesions. They look like little spider webs inside my endometrium. How do I see this? Is through SIS, or histosalpingogram, or sonohistogram. Either one. They're both called, they're used interchangeably. I have squirted water inside my endometrium, causing my endometrium to expand so I can see the inside lining of it. Okay, so Asherman syndrome or synechia, they are uterine adhesions. Okay, you can have normal to absent menses. If the internal os is blocked, then no blood can get out. Okay, then what's my patient going to have? Hematometra. Okay, hematometra. Okay, so you can, it causes recurrent miscarriages because there's no place good for the blastocyst to implant. Okay, if I'm even able to get pregnant, because adhesions also cause infertility. Okay, how am I going to do this? How am I going to make the diagnosis? Is a hysteroscope that is done in the OR. It's not done in the ultrasound department. Histosalpingogram, salpingohistogram. They're used interchangeably. Okay, those we do. We assist the radiologist in putting the catheter in through the vagina, into the cervix, into the uterine canal. We are the ones that set up that tray. Okay?
Oh, so we'll be learning.
Oh, yes. You should already hopefully be observing them now.
So they do the procedure in order to give the diagnosis? Is that the reason?
Exactly.
Okay.
Exactly. Because we see something's in there, but we can't tell what it is. We can just tell something's not right. So they have to blow it up. They have to put water in there for us to see it. Okay? So an HSG is a diagnostic exam that we do inside sonography. Okay? We're the ones that set up the trays for that. You'll need a speculum, you'll need the catheter, you'll need a couple of syringes, 10 cc syringes, and you'll need a bottle of saline. Okay. So here they have put water inside the endometrium. They have dilated the endometrium with a SIS, which is the same thing as a HSG or a SHG. It is also called a SIS. Saline infusion sonohysterogram. Okay? And it helps us see adhesions or synechia or scars inside the endometrial cavity. So, I don't know how to pronounce that. Dehiscence? Have no idea. I'm just guessing. Okay, never even heard of this word until today when I was reading it. It's basically a rupture of a synechia or an adhesion, or what happens is it becomes detached from the uterine wall. Well, what feeds the uterine wall? The radial the spiral and the straight arteries. Mm-hmm. So if it tears an artery, it's going to bleed until it clots off. Most of the time, it's caused from myomectomies, meaning I've had a fibroid and they've removed it. Okay? They're also called a myoma. Okay? It's a fibroid. I could have had an instrumentation where they went in to dilate my cervix because I have amenorrhea, and they could perforate the uterine wall, and that will cause bleeding. Or a C-section. A C-section is important for us in OB because if the placenta implants over the scar, then those placental cells can migrate up the scar into the myometrium, out of the myometrium, out of the serosa, and into my abdominal cavity. Okay? Mm-hmm. It can adhere my bladder, and if I give birth and it comes off, what's going to happen? It's going to rupture my bladder. So it's important that we take a good family medical history on our OB patients, because if they have had a C-section, we want to be sure to look at that area very well as far as the placenta is concerned, with color, because that's the only way we can make that diagnosis. It's called, what are they? Acreta, Encreta, Percreta. Acreta, it's into the myometrium. Encreta, it's all the way through the endometrium. Percreta, it has penetrated the serosa. But we're going to study that. Okay. Uterine scarring or dehiscence, there's that word again. Symptoms, you have pain and dysmenorrhea. Dysmenorrhea is painful periods. Sonographically, the lower uterine segment will be thick You'll have linear anechoic area at the C-section site. C/S means C-section. And you can have a defect into the myometrium. Here is a rupture at a previous C-section. Here is my cervix with a little bit of fluid. Here's my lower uterine segment. This is a bikini cut. So what happens is they cut it down here underneath the belly, and you can see that you've got a little triangular defect. Anytime, no matter where you're looking at in the body, if you have a triangular defect, it's abnormal. Okay? You can see it at the cervix, the lower uterine segment, and the endometrium. If you see that little triangle here, then you have something in the endometrium. If you have it up here near the chest, you have a pleural effusion. Okay? Leiomyomas. They are the most common benign tumor of the uterus. Okay. This I don't agree with. Okay. I've always called these intramural. So let me find it in the book and see what the book says. Okay. You have subserosal.